Hello, I'm happy to present an interesting electrophysiology case from Henry Ford in conjunction with Dr. Sean Gandolfo and our mentor, Dr. Mascoon, titled A Curious Case of a Highly Isoproterenol-Sensitive Retrograde Accessory Pathway with Clinical Orthodromic Atrioventricular Reciprocating Tachycardia. We have no relevant financial disclosures. By way of introduction, patients with supraventricular tachycardia can often have dual AV nodal physiology without manifesting AVRT clinically. Similarly, patients can have weak bystander accessory pathways that do not conduct well enough to allow for AVRT and are considered bystander pathways. Hence, a thorough EP study is required to properly differentiate between AVNRT, orthodromic AVRT, atrial tachycardia, and junctional tachycardia before proceeding with the appropriate ablation procedure. Accessory pathways that participate in orthodromic reciprocating tachycardia, ORT, circuits typically have stable conduction properties that are unaffected by beta agonism and sympathetic tone. Studies have shown that a minority of patients can have antegrade conduction significantly respond to isoproterenol during EP studies, but even less commonly for retrograde conduction. We present a case of ORT involving an accessory pathway with conduction highly sensitive to isoproterenol. For our case description, we have Mr. N, a 29-year-old male with a history of frequent palpitations and highly symptomatic SVT as recorded on his smartwatch, seen here, with heart rate as high as 220 beats per minute. He was referred for EP study and possible ablation. Notably, his resting EKG showed no ventricular pre-excitation. His initial pacing maneuvers showed dual AV nodal physiology with no pre-excitation, but his RV pacing did show an intermittent left-sided eccentric retrograde atrial activation seen here, suggesting weak concealed left lateral accessory pathway. As we can see in this figure, this pathway is blocking at a cycle length of 570 milliseconds of RV pacing, suggesting weak conduction that was initially felt not to be robust enough to actively participate in a rapid SVT, making it a bystander pathway. Tachycardia was unable to be induced at rest, but with isoproterenol, sustained SVT with cycle length of 260 milliseconds was easily induced extra-stimulus atrial pacing. And the atrial activation pattern was, again, eccentric, similar to what we saw with our RV pacing on the previous figure. Standard additional EP maneuvers confirm that this was, in fact, an ORT with the accessory pathway now conducting rapidly in the presence of isoproterenol. The accessory pathway is localized to the posterior lateral position on the mitral annulus due to significant improvements of the ventricular atrial conduction using the AV node as well on isoproterenol seen here in 2C. We elected to perform mapping of the earliest atrial activation for the accessory pathway with LV pacing on a lower dose of isoproterenol to avoid this issue of fusion. Loss of retrograde accessory pathway conducted occurred within 1.5 seconds of 50-watt radiofrequency ablation seen here. And he was no longer inducible for tachycardia, and the accessory pathway conduction was absent with and without isoproterenol after a 30-minute waiting period. No events with 3 months of follow-up. Accessory pathways are known to generally have fixed conduction characteristics due to their anatomic composition of non-specialized myocardial cells. However, multiple case reports and small retrospective cohort studies have demonstrated that isoproterenol can augment conduction in both an antegrade and retrograde fashion, at times even completely unmasking a concealed accessory pathway participating in clinical SVT that is completely absent at rest. This case illustrates the importance of a complete EP study, including the routine use of isoproterenol in SVT cases. The initial identification of dual AV nodal physiology and the weakly conducting concealed retrograde accessory pathway suggested a likely AVNRT. However, when SVT was induced with isoproterenol and revealed the eccentric atrial activation made possible by profound augmentation of conduction via the accessory pathway, along with other standard EP maneuvers, the diagnosis of ORT became clear. Had the study concluded without the use of isoproterenol, the correct diagnosis likely would not have been identified. In conclusion, catecholamine-sensitive accessory pathway conduction is uncommon but critical to identify in a complete EP study using isoproterenol to ensure accurate diagnosis of a patient's SVT. Thank you.